Green?
Now just press one. Okay. Hello, everybody. Thank you to the ISHAM Histoplasmosis Working Group meeting. This is the first meeting we have joining all of you people, and I'm quite happy to be here chairing this meeting here with my colleague Antoine Adini. I would like, first of all, to thank people who have worked for this to happen, especially the sponsors, Freddy from PAHO, and some companies, Knight, Mira Vista, IMI, Diego, thank you. And also we are doing this in collaboration with the European Society of Clinical Microbiology and Infectious Diseases and our local infectious disease society from Rio Grande do Sul, Brazil. This is a very busy meeting, so I'll ask please the speakers to be on time. I'll be ringing a bell just to let you know that we have 1 left minutes. And we'll have some time for discussion. And in the end, we hope to finish with a call for action for histoplasmosis, what we really want for histo in the future. Antoine, please.
No, sir. You already said. So hello, everybody. Thanks for coming. We're very glad to have you. And so we want to put this meeting in the perspective of the last international advocacy group meeting in Manaus. We had a call for action at that time. And so now, by the end of the meeting, we want a call for action for 2030. So we will make you a proposal, probably just before the coffee break, so that you can think about this, and so that we may aim and gather and commit with something by the end of the meeting. So I'll let now Nelesh, thank you, chairing the first session, so that you can introduce the session. Thank you.
Alessandro, this is a great meeting. Obviously, we're starting with the latest.
Sorry, cross you.
Great, good morning.
Sorry,
good afternoon. On me here? Okay. Anyway, it's great to be with all of you at the end of a great issue meeting, now the beginning of this first sort of working group meeting. I'm just going to give a really brief overview of sort of my thoughts on this disease, which we really have been focusing on now for many years, and we still have a lot more to do. I always like this slide. I think Diego actually first made this for me a long time ago, but it's a slide of 3 patients with HIV with disseminated histoplasmosis, right? Something that we see, unfortunately. But what's not the same about them is where they're from. They're from 3 different parts of the world. And, you know, I think traditionally we've thought of this disease as an American problem. This is an American disease, it's an American problem. And certainly it is. And certainly some of the highest rates in the world are in parts of the Americas, as we know. But it's really a global disease. And so we have to think about global solutions for this disease, not just American or Latin American or Caribbean solutions. I think our maps are also probably not very accurate. We call these diseases endemic. I like to call them geographic, but at the same time, I think even something like cryptococcus, which we say is everywhere, there are still hot spots for crypto, and histoplasmosis is no different. I think that, you know, the key with this disease in my mind is detection, detection, detection. We have to diagnose people rapidly if we're going to save lives. I think this is a lovely example of how Colombia really dramatically improved the diagnosis when they had a rapid test, identifying much more people with disease and saving lives. I think Diego Falsi here in Brazil showed a very similar phenomenon when they tested with antigen test. They got much better outcomes than with conventional diagnosis. And we in the United States have been pushing the idea of testing community-acquired pneumonia in high-risk areas. So these are non-HIV. These are just people coming in with community-acquired pneumonia, and we want to see fungal pneumonias be diagnosed. So histo, cocci, blasto in the United States. I think we've been at this for a little while. We formed the International Histoplasmosis Advocacy Group many, many years ago. You can see back in French Guiana and Suriname, right? This is, I didn't, you know, I was looking at this slide, I realized it's already been like, what, 12 years? It's like, wow. And then You know, we've been trying to meet as a group, trying to build advocacy and awareness. And this was a meeting we had in Manaus. I guess it's really the last meeting of IHAG. We were planning to have another one, I believe, in Panama. I know, Alessandro, you've hosted some sort of meetings like this in Brazil recently. But again, it's great to be able to do it here. And at that Manaus meeting, and this is probably what these guys are going to talk to us about later, but at the Manaus meeting, we did a declaration where we wanted 100% of countries to be able to diagnose rapidly histoplasmosis and get treatment by 2025. Well, guess what year it is? We're in 2025. So I know at the end of this year, we are going to at least put a report card about where we are with this 100%. We are not at 100% yet. I don't think we'll be there at the end of the year, but we've certainly done a lot, and we are definitely closer to 100% than we've ever been. We also, working with Freddy and others at PAHO, were able to publish the first ever guidelines on diagnosis and treatment of HIV-associated histoplasmosis. And I think to end, this is my last slide, so again, I'm going to be very brief. You know, these are, I think, the three areas that at least CDC, working with all of you guys, are focusing on. Lab diagnosis, drug availability, so access, and then finally the treatment quality and making sure we have the right drug for the right patient. So with that, I'll say thanks for letting me introduce the topic, and obrigado, and I look forward to the discussion.
Thanks, Tom. Thanks for keeping to time. We've got 10 minutes at the end of the discussion, so we'll keep our questions till then. Our next speaker is Dr. Freddy Perez from PAHO, and he's going to be talking about ongoing initiatives in PAHO. Thank you.
Obrigado. So thank you very much again, and good afternoon to all of you. I have 8 minutes, and we'll go quite briefly, then we can have some discussion later on. So I've been asked to present what is ongoing initiatives at the Pan American Health Organization. To continue this? Okay, sorry. Okay, so what I'm going to do is, as an overall umbrella, we are working now with a Unitaid funded project that guides us very much of what we're doing at the moment on HIV, advanced disease, and opportunity infections. 5 main components that are there. I'm not going to go in detail just to highlight the issue of. I'm very much into the first one, which is generating evidence and improving epidemiological data implementation research. We have the support of the procurement side, another component, and then guidelines, regional and national guidelines, third component, promoting community engagement, and also the issue of partner coordination. Partner coordination is the reason why we have been very interested to support this meeting here also. So some of the slides, some of you have maybe seen in another session, but I will go briefly. What we're doing now is, very importantly, is we're supporting a HIV advanced disease data board currently in progress, aimed at visualizing epidemiological data on HIV advanced disease. This is collecting data to try to look at trends in many topics linked to HIV advanced disease. And this is a topic that we discussed in other sessions. How can we improve a coordinated platform of databases? Also, as I mentioned, we are also working on a database of evidence-informed recommendations, which means this is for clinicians, for decision makers in hospitals. They have this platform which is accessible at the PAHO website to be able to see which are some of the clinical guidance, clinical recommendations linked to HIV advanced disease in the different topics. Generic protocol is something that we are very keen. This is the second version of the one on HIV advanced disease. A big challenge has been in our experience on the first countries is to respond to the question, what is the cost, what is the cause effect of our interventions? Big challenge. We cannot do randomized control trials. We cannot have a control group. So this is a new protocol that we're starting to implement in a scale-up way, so we can maybe compare sites that are starting, that will start. So this is a new protocol, a generic protocol. A second protocol is the one on generic protocol to look at HIV and TB-associated mortality in Latin America, to look at access to specific reporting accuracy, causes of death linked to HIV advanced disease or TB, also identify some gaps in the health system. Health systems, I have not heard in this conference too much. This is something that we are very keen, and hopefully we can discuss more. Which are the gaps not only on the testing, on the diagnostics, on the management of patients, but what is the gaps on the health systems in our countries? This slide, some of you saw already. This is an update of where we are implementing rapid testing on crypto, histo, and TB in Latin America. Some countries we have already completed, some are ongoing. Here is some data showing, and I've highlighted for histo, we are on the histo meeting showing where we are on HIV advanced disease in Brazil, in Paraguay, Trinidad and Tobago, and recently we finished our best practice, I would say a demonstration project in Guyana that we were finishing a manuscript for that. And of course, we need to communicate. One of the means to communicate is scientific publications, which with my colleagues, and not only in Brazil, but mainly in Brazil, I have to say. We have been done quite a few issues. An important thing to highlight is we need to do more qualitative studies. I think that's something that is important. Here we have an example that we did in Porto Alegre. This is new projects that are ongoing now in 3 countries, in Dominican Republic, Colombia, and Ecuador, which we have initiated already. Mainly in second level hospitals that we are ongoing, implementing the new generic protocol that I mentioned briefly. Another issue that's a key priority for many of us here is the TB histo co-infection. So one of our colleagues here, we have a poster in this session here, which congratulations to our colleagues in Porto Alegre. But we have put together now a generic protocol for to do a meta-analysis, and based on the information that we have for 4 countries now. So this is something that we would like to move forward. And another example of how we can share data together and improve data of topics that sometimes are not, so we don't have too much information. So we're going to start this with a group of colleagues in the 4 countries to do a meta-analysis of the TB histo co-infection. To look at what? To look at access mortality, document treatment, which is a big challenge, as you know, as clinicians, and also to look at what we need as support for evidence-based management of these patients at different levels. Another topic that we are moving forward, and thank you for my colleague, Rafaela, for this slide. We are doing a prevalence of histoplasmosis in the state of Rio Grande do Sul. Here I'm highlighting the hospitals that are participating to look at the prevalence of crypto, histo, in HIV patients. I've highlighted something that I think is very important that we discuss is we need to look at how can we improve the surveillance systems of these infectious diseases. And my understanding, example in Brazil, is that there's only, I think, 1 or 2 states that have a real surveillance system. So I think this is very important. To do that, we need to work with the local government. And this is something that PAHO, we're very keen to support, but we need to work with the local government. We need to work with the local health systems to make this sustainable. I'm going to go quicker. So these are the national guidelines that we have been able to support based on the global regional guidelines, supporting countries for national guidelines.
1 minute.
Thank you. And the last issue I would like to mention is our very important support with our strategic fund department on the procurement of drugs and tests. Here we are looking at supporting strategic procurement, and also here's the strategic fund with the list of the packages. 2 issues to finish. We are working on the guidelines clinical guidelines, regional clinical guidelines, and also laboratory guidelines, mainly to look at quality assurance. This is another issue that for us very important, quality assurance. And finally, we have finished the research prioritization of research in Latin America on HIV advanced disease that's going to be presented in the International AIDS Society meeting soon. And this here just some information. We have quite a few questions on health systems that we have come up to, also treatment, risk factors, prevention, based on a modified Delphi study that we finalized with some of you here in this meeting. And finally, the importance of looking at new guidelines based on research that is going on. Thank you very much.
Excellent. Thanks, Freddy. That's a very stressful format. People are having to keep to their time. Our next speaker is Dr. David Denning from the UK. We'll be talking about MDR-TB and histoplasmosis.
So I'm going to change topics a little, and I'll talk about disseminated disease, but about chronic pulmonary aspergillosis, or histoplasmosis, actually. So many of you will have seen this paper on how many infections there are. There is a line in this table of disseminated histo in HIV patients, and this is one of the most uncertain estimates in this whole paper. The data outside Latin America is really pretty awful. I relied a lot on Antoine's paper for Latin America and Caribbean, but the rest of the world is uncertain. So there's a real problem here. But what I want to focus on a bit more is chronic cavitary pulmonary histo. The radiological manifestations are pretty variable. They're quite different, actually, from chronic pulmonary aspergillosis in many, many examples. And the other problem is that this is a co-infection problem of aspergillus and histo. And this old piece of work from the US shows this, and it also shows, if you look at the lines, that some of the patients are histoculture positive and some of them are antibody positive. And so that is the usual way the diagnosis was made, on histoantibody plus culture. And in Brazil, there was a big study looking at multi-drug resistant TB, which is what I'm going to cone down on. And in that older study, 3 of the patients had aspergillosis and 4 of them had paracoxy. But it isn't clear whether they looked for histo. We don't know if they did or not. So in some work we did in Indonesia, a small study, 50 patients with proven MDR-TB, so there was no uncertainty about that. We looked for a histo-IgG, which was the Miravista test, which Joe Wheat kindly provided. It was a mission, and you can see about a quarter of the patients were histo-antibody positive, and we also did the LD-Bio IgG-IgM testing. About a third of the patients were positive, and 12% were positive for both of those infections. Now, this doesn't prove they had CPA or CPH because we didn't have culture and metagenomics and other things on there, but it's highly suggestive. And one of the ways that this diagnosis can be made is with antibody, and from Rosalie's group, she has validated this Western blot assay, and for pulmonary disease, it really performs pretty well. You can see it's got a little bit of cross-reactivity with paracoxy, aspergillus, and TB. Probably they're co-infections actually rather than cross-reactivity, but that wasn't worked out. But the sensitivity and specificity are really very good for this assay, but it's not available commercially. So it's available in Brazil, but not elsewhere. And that's a problem. And there's no commercial PCR for histo either, which is another substantial gap. So in this work we did in Indonesia, we did a single point cross-sectional study at lots of different times after starting treatment for TB, and this is the time frames that you get there. And if you look at the outcomes during the time we looked at it, 4 of 26 patients who had antibodies died, none of the others died, which suggests that this is a significant co-infection, but clearly there's loads more work to do in this area, and it's important. So how many MDR patients are there globally? Well, the WHO tells us that there are around 400,000. So some of these are genuine MDR, and some of them are just RIF resistant. So there's a combination in that group. These are the distribution by country. So if we take away the the regions where there's very little histo, and just stick with the regions where there is histo, that's around 300,000 patients who are at risk. And one of the risk factors for a co-infection is cavitation. And Ian Page went to Uganda and did this 400-patient study looking for aspergillosis. And what we found was that the rate of chronic pulmonary aspergillosis was 33 times greater if there was cavitation following the treatment of TB. So cavitation is probably a big risk factor, at least for aspergillus. Don't know for histoplasmosis. And so what are the predictors of cavitation amongst patients with TB? And one of the risk factors is MDR-TB, a risk ratio of 2.3. And isoniazid resistant was in fact the biggest risk factor, and treatment failure, which is possibly a proxy for that as well. But RIF resistant was not a risk factor for cavitation in these patients. So if we take this denominator of about 300,000 patients with MDR-TB across the world, and we take away the ones with RIF resistance, then you're left with about 90,000 patients. And in that group, that is the group that's particularly probably at risk for aspergillosis or histoplasmosis. So at this meeting, Romy and her colleagues in Venezuela looked at antigen detection. So to my knowledge, this is the first time anybody's looked at antigen detection for histo in chronic pulmonary aspergillosis. And this is a very big study. This is bigger than any of the studies which has been done with antibody. 282 patients. And broadly speaking, the antigen was about 50% sensitive. Well, that's an awful lot more sensitive than no testing. It may not be perfect, but it's actually very helpful. So where does this leave us now? We do need prospective and cross-sectional epidemiological studies in areas of high and medium histoplasma endemicity. We need a better description of the radiological features of these diseases compared with TB, MDR-TB, NTM, CPA, etc. We need documentation of at-risk patients, and we need to follow them. We need a consensus definition of chronic pulmonary histoplasmosis, which doesn't exist, to my knowledge, and that needs to include antigen testing now. We need correlative data between histoplasma antibody and PCR, respiratory PCR. We need modern treatment studies of this disease. There's essentially nothing in the literature on treatment, to my knowledge, in this area. And we need longitudinal studies to understand what the natural history of this is. So with disseminated histo in HIV, starting ARVs often resolves the infection because the mortality is probably not 100%, as you've seen from many of the epi studies. But we don't know for CPH. We don't really know. The data dates from the 1950s and 60s on outcome, which is clearly unsatisfactory. And we also clearly need this much greater awareness about co-infection. So with TB, with NTM, with aspergillosis, with Paracox C, etc. Many thanks.
Thank you, Dave. I'm going to introduce Dr. Bahr. He's going to talk the market management experience in MSGERC point of view. Thank you.
Right. All right. Thanks very much. I will try to stick to time too. So I was asked to talk about the MSGERC, and I can hardly get the whole thing out. So I understand if everybody doesn't know what that means to start with. So I'm going to try to give you some of that info if you're not aware. So this is the Mycosis Study Group Education and Research Consortium. And so the long name does tell you kind of what it's involved, right? So this group focuses on education. This is we're very interested in how our teaching about fungal infections in particular. I'm interested in how and medical education seminars. That was really started during COVID. There are cooperative agreements in place with CDC. Tom talked about one effort that MSG was involved in with the community-acquired pneumonia education in the US. And this group also helps identify leaders for public health education efforts. So, if CDC is interested in a project in some area, they will at times talk to MSG about who might be a good fit, although they already know who they want to ask, I suppose, anyway. The other things that are there are this Fungus Education Hub, which is a website where many of these educational efforts are housed, and then Dr. Fungus, which is a website that's been around for quite a long time and is being worked on to be updated a little bit so it doesn't look as much like it's been around for quite a long time, but that's the idea there. In research, this was, MSG once upon a time was actually an NIH network, and then that funding was not continued, and MSGERC was established after that. And so that's sort of where it started with research, but the group does a lot of work. Operations are fostered within, and there is a CDC contract for targeted research studies, and endemic fungi are really a point of emphasis for that, I think I've been told. So this was a picture from the biennial meeting that, as you can guess, is every couple of years. From the perspective of the US, I guess I just wanted to emphasize a couple things. One is that, as has been said, I think we're learning more and more about where this is really happening. We have our traditional setup in terms of where a lot of cases happen that we've known about for a while, but we're learning more all the time in terms of other places where this is occurring. And you can see that, I think very smartly, CDC in their makes it quite clear that there's a possible range throughout basically the whole country. And I think that's sort of a smart approach, because we do hear a lot of folks saying, well, I don't have a histoplasmosis case. It can't be because I live in, Oregon or whatever it is. And so this is one approach to try to help with that. But we're learning as we go along. And then of course, I was asked to include some about North America, and I will say, of course, I know a bit more about what's happening in the US than I do Canada or Mexico, but we're definitely aware that there's cases in these areas that were areas that we didn't used to talk about, but we know there are cases happening. And of course, with this map as well, it's I just emphasize again, just because it's not on the map doesn't mean we're saying no. The other bit I thought I'd talk about a little bit with antigen access or with the US side of things is really just antigen testing access. So, we've had antigen testing accessible for a while, and of course we realize that is a very good thing, and we're lucky to have that. But this is variable by region of the country, it's variable between countries, and turnaround time, of course, has been a problem for quite a long time. And so, for the longest time, it was really one lab primarily doing it. And so, that was okay if you happened to be very close to that lab, but your turnaround time was quite long if the sample had to be mailed from the Western United States to the Midwest, right? And so that is something I think that's a point of emphasis, and hopefully these lateral flow assays will improve that as well. So I thought I'd cover a couple of just very broad trends of sort of what we see in the US to say, we do have these areas of hyperendemicity, but we have risk in a lot of areas, and that's probably underappreciated. I think a lot of folks in the US would like to imagine that, advanced HIV is sort of a thing in the past, and that's clearly not true. We still see folks with very advanced HIV and disseminated histoplasmosis. We do, however, see a lot of histoplasmosis also in people without HIV, with other forms of immune suppression, be they from transplant or autoimmune conditions that require immune suppression, or simply people with, as far as we know, normal immune systems that get exposed to a big load of histoplasmosis. We do see disseminated disease, we see pulmonary disease, we see a lot of nodules. So a lot of hospitals have lung cancer screening programs set up, and a lot of these get cut out, and then they tell us that there's a bunch of histoplasmosis in this old nodule. So that's a pretty common scenario for us to see as well. And then I guess the last thing I thought it was sort of, it would be sort of inappropriate to talk about the US landscape with histo right now and not talk about the elephant in the room, at least a little bit, which is to mention there's just a lot of uncertainty right now. So we don't know in a lot of cases, sort of what's going on and how this is going to affect it. I would say we have a lot of willing partners for collaboration, but we are uncertain how government policies are going to affect some of these things. And so, yeah, let me just say our scientists remain willing and very excited to collaborate. So thanks for the invitation. Thanks, Alessandro and Antoine. That's all I have.
From US to talk how to teach histoplasmosis. Thank you very much.
Okay, so I was asked to talk about how we teach about histoplasmosis, and I decided to focus on what we teach incorrectly and how some of these stereotypes and misconceptions can perpetuate and in fact lead to dangerous situations where the diagnosis is overlooked because of some of these anachronistic thoughts. So I have no disclosures. So I've chosen 3 of the misconceptions that we perpetuate. This is certainly not an exhaustive list. So as Nate already highlighted, our understanding about the geographic range of histoplasmosis is evolving, but in many people's minds, they're really anchored to this map, this original map about, the hyperendemicity in the Ohio River Valley. And, this was first established by Edwards in his study of histoplasmin skin reactivity of tens of thousands of naval recruits, which was really an ingenious way of creating an initial map. But instead of using this as a starting point, we've really anchored onto it. And consequently, there are many places, not just in the United States, but around the world, where a clinician might not think about the diagnosis or relegate it to the bottom of their differential, because the patient hasn't been to Ohio. In fact, Nico Barros shared an anecdote with me about when he was training in Peru, and some clinicians would say, well, the patient hasn't been to Ohio, so there's probably not histoplasmosis. So we've already seen this map at the bottom in contradistinction to that classic map that was derived from the histoplasmin skin reactivity. So on the bottom, this is where cases of histoplasmosis are being diagnosed according to Medicare claims. And this is work by Andre Speck and colleagues. And so it demonstrates that really there's many cases that are being diagnosed outside of the classic region of geographic risk. But this doesn't tell us where these cases were acquired because, of course, there's a long latency between infection and the development of disease, and people travel. There are ways, though, that you can establish whether histoplasmosis occurs in an individual area. One way is if you can culture the fungus from the soil. Of course, in practice, that's not done anywhere. Another way is if you have somebody who has never traveled, but I'm always a little bit distrustful because when you ask, more probing questions, usually there is some kind of travel history. So one way is by investigating outbreaks where you can triangulate exactly where an infection occurred based on 2 individuals that overlapped in time and place and both developed the disease. And so we did an outbreak investigation in Alberta, and showing you here where Alberta is on the map in contrast to that classic region of geographic risk based on the Edwards map. So it's about 2,000 kilometers from the lower border, the southern border of Minnesota, which was portrayed as being as far north west as the fungus goes. We were able to establish based on outbreaks that the fungus does in fact occur locally. Nate shared this map, which in fact he was instrumental in leading in collaboration with the CD. And we've tried to reflect the uncertainty that's inherent to having a map. And there's
some fuzziness at the borders, and also reflecting, some of these regions that were previously neglected, like Africa, Asia, and even parts of Europe, that the disease does occur. So the second misconception is an association in the exposure history with bats or birds. Medical students are taught to think about histoplasmosis only when they're presented with a case like this, somebody who gets sick after spelunking. And of course, we know that most patients don't have such a history. It is true that most outbreak-associated cases can be linked to bird or bat guano in one way or another. In fact, 3/4 of such cases report an association, at least in the published literature. But when it comes to sporadic disease, only about 1/4 can recollect being exposed to bird and bat guano. And the fact that sporadic disease actually comprises over 95% of cases means that fewer than 30% of patients will actually have some kind of exposure to bird or bat guano in the history. And then finally, we treat histoplasmosis as one disease caused by one pathogen. And so I have a photo of Sugarloaf Mountain from Rio to demonstrate this kind of monolithic representation. In reality, the genetic and biological diversity of histoplasmosis is quite vast. This is a phylogenetic tree from Daniel Matute's group and colleagues, and this represents the incredibly rich diversity. These cases with the yellow line beside are isolates that were recovered just from the Amazonian basin. And so there's way more genetic diversity than previously acknowledged. In fact, there's at least 12 different monophyletic clades, many of which have already been given species names. There are indeed some phenotypic differences. This has been demonstrated by Bill Goldman and Vicky Sepulveda and Daniel Matute over the last decade or so. For example, there's differences in the colony morphology. If you look at Histoplasma ohioense, it has this smooth colony formation because of the absence of alpha-1,3 beta-D-glucan in the cell walls. Sure. Histoplasma mississippiense also has extracellular proteolysis that is absent in the other isolates. And also there's differences in pathogenicity. This has only been studied in a very small number of isolates. So really, we're just touching the surface of what we understand about differences between these different taxa or clades. So clearly, the reason that we teach like this is because it's easy for students to anchor to a specific association or a stereotype, and it makes for testable questions. And so we need to, I think, be thinking more holistically and move beyond just teaching for the sake of an examination. So I'd like to thank you for your attention. Thanks for the opportunity, and look forward to chatting with you through the course of this day.
Thanks to the speakers. Students and I've got questions. So the session is open for questions. Can I ask another question? Just about really talk. There, so we're working with patients there. So, where is the development to work?
Let's put here. Here? Also.
Eu falo aqui. Hã?
The reality is also that people can only keep a little bit of information in their brains, and so we need to be strategic at where we have these targeted, outreach to the general public. So certainly in areas of high geographic risk, we need to be teaching not just clinicians, but also patients. The reality is though that often the patients know what they have to come in and they get at risk because they're more aware than the clinicians based on where they live or where they travel. So I think you're right that it needs to be multifaceted, targeting healthcare workers and the general.
So I was talking with Ilan and Nate the other night about screening for lung cancer, which is now really common. And CT scans and scopes are doing any form of lung. And of course, it's lung cancer, so they're particular. And we found a small number of those just, but there's a larger number in America, which are Histoplasmosis and there are some which are not. And I think we also need strategically some really good work on how we diagnose that to save patients that are vectors and reconstructions. And I think that's quite urgent in the advanced clinical companies, particularly in the US.
Thank you. Any other comments or questions?
I have a question for Ilan. I would like to know, how do you map the endemic areas in US? The methodology you use?
Yeah, so the original one by Edwards was based on histoplasmosis.
Mm-hmm.
That test is not available anymore, and of course we're a lot more mobile now than when those were initially mapped out. So there's a few ways that we can determine with certainty if histoplasmosis is endemic to a certain region. As I mentioned, culture-based diagnostics. Some people, or a lot more labs, are using molecular-based detection in soils, which I would say doesn't have the same gravitas in knowing sort of what it means. And then if you have cases that clearly are well documented as never having traveled, in practice, people do travel, and so this means a diagnosis in a very young child or even an animal that doesn't have a wide range that they cover. But in practice, the best way is going to be through demonstration of outbreaks. Now, in order to do that, you need to have a public health system that reports cases and then investigates cases. And certainly this was the case in Alberta where we did this investigation. But in most Canadian provinces and also most US states, histoplasmosis is not reportable. And when it is reported, it doesn't necessarily lead to any sort of exposure information. And healthcare is very fragmented, so there's not an amalgamation of this information across a state. And so we lack this information in most cases. And then the other challenge is that these things are very dynamic, and we are anchored in a specific cross-sectional study that was done at some point in time, but that doesn't mean that those maps remain static. And certainly, with climate change, we think about this more with cocci, but likely to occur similarly to an extent with histoplasmosis. And so we need a way of not just mapping it out, but also to revisit these maps as well.
I have a question. Okay, I have a question. It's okay for you?
Go ahead.
Okay. It's for Freddy. Freddy, I'm not sure I noticed well, but do you think so that in those dashboards, advanced HIV dashboards you are implementing, so will you report these operational research protocols results in the end? So will you report the proportion of people who will be screened for the disease, or is it only advanced HIV? So it's the number of cases and it's number of deaths from advanced HIV, or there will be specific column to qualify what is advanced HIV and what's the mortality among them?
Yeah, hello? Yes, so
The two of them.
oh, yes. So this is work in progress, first of all. What we're doing now is we're trying to collect information not only from the implementation research project, but also working with ministries of health to be able to collect their information. In parallel, we are working with the national AIDS programs mainly, but not only, also the TB programs and ministries of health to help them improve their data collection, in this way trying to decentralize. Example, issues that we are trying to have a better idea is the cascade of the HIV advanced disease, from testing to treatment to short, medium-term follow-up, to be able to see the morbid mortality of these patients. And at the same time, we're working with the TB programs and ministries of health. Our counterparts mainly are ministries of health, but not only, we are trying to include at the same time implementation research data that is coming in. And this will be shared with, but this is, as I said, is work in progress at the moment, trying to identify which are the main principal variables we would like to collect. So I can come back with more information when we have this finalized and ready, but it's work in progress.
Because we will need this to evaluate any strategies we want to implement, but also it's one of the main drawbacks on these data, the global data that we have, and this is how we show up the problem in Tanzania, because we ask the question, what is AIDS? It's not about AIDS numbers, what is AIDS in the numbers? So I think it's very important that we find a way to inform the system.
I agree with you, because this data will help us maybe relook at the definition based on the profile of our patients and based on the data that we are collecting. I agree with you.
Thanks very much. So I think we're done. Thanks to all the speakers for setting us up for a really good rest of the afternoon. Thanks to Rosie, my coach.
Thank you. Oh,
So hello everybody, I'm Alastruey from the Mycology Reference Lab in Spain, and is the microphone working, this one? Yep. Yes, perfect. So I'm gonna share the session on the best topic, which is collaborative research. So the first speaker would be Alessandro, and it's gonna talk about the Brazilian network, introduction and factorial trial. Alessandro, the floor is yours. And I'm going to be very strict with the time. Huh?
Yeah, I hope to be on time. All right. So thank you all again to be here. And I'm going to just present you what we've been doing recently in Brazil. We call the Brazilian network of histoplasmosis. This is my disclosure, not much to show you, but we published this 2 years ago. This is a phase 2 trial evaluating safety and efficacy of a single high dose of amphotericin B, liposomal amphotericin B versus the standard of care, which is 3 milligrams of ambisome for 2 weeks for induction therapy of disseminated histo in HIV. And at that time, we were working with 6 medical centers in Brazil. The study was done during COVID time, so wasn't easy to include patients. But as you can see, most of the cases came from Goiânia, which is the hotspot of histo, the known hotspot of histo in Brazil. And also these 2 important cities, Fortaleza and Natal. We had 3 medical centers in Porto Alegre, and we were able to include only 11% of cases. So basically, when we think of histo in Brazil, we think of these 3 medical centers. But in many areas of the country, the disease has never been properly studied. So this is the summary of the results. Just to summarize, we evaluated clinical response on day 14, and the single high dose of ambisome had a similar clinical result in comparison with the standard of care, similar survival, and lower toxicity. So we think this is the way to go. We probably can do induction therapy with a very short regimen, such as we do for crypto and leishmaniasis in histo. But this was a phase 2 trial. Now combining all of the results of studies using the single high dose of amphotericin B, this is a meta-analysis published also 2 years ago. So basically it's our study here and 2 studies with crypto and very similar results. So reduced toxicity, grade 4 adverse events, renal grade 4 adverse events, hematological toxicity, and similar survival. So we were quite excited about that, and then let's move to a phase 3 trial, because this wasn't enough to convince others, like those making guidelines to change clinical practice. So this is what we call the induction trial. This is an ongoing trial, phase 3 studies. Now we have 16 centers in Brazil, so much bigger study. We expect to include about 300 patients, a bit less, and we randomize patients for andisome in a high dose or the standard of care therapy for 2 weeks. But now we changed the primary endpoint from clinical response to overall survival, because it's much easier to measure, because clinical response is a bit subjective. If the patient is doing better, but maybe fever has gone, but the patient still has some skin lesions or jaundice, so it's more difficult to define a response. And secondary endpoints now they are going to include the clinical response, toxicities, decrease in urinary antigen titers, PCR as a surrogate marker also of response, and the DOR outcome, which I'm going to show you quickly soon. And also secondary endpoints include now survival at week 10. In the phase 2 studies, we followed patients for 1 year. Now we're going to follow them for only 10 weeks. Because the target here is just induction therapy and the need for additional courses of amphotericin B. So the DOR scale is like this. This is our proposed DOR scale. So it's not only saying the patient has died or survived, but survived with toxicity or no toxicity. So it's an ordinary scale, and we hope to show superiority in the DOR scale for patients using the single high dose. So this is the map in Brazil of the centers we have. So we have centers from the north parts of Brazil, and there are a lot of history around here. And the traditional centers we had in Goiânia, Fortaleza, Natal, but more centers in the south, Bahia, with a lot of cases of history too. So it's more fun now. It's more interesting because there are more people interested in joining this network. So 16 medical centers so far, more than 700 patients screened, and most of the cases now are coming from the south, which is a big surprise for us. And only 50 patients enrolled so far. But this is what we've got so far. We got a donation of andisome from Gilead, so more than 10,000 vials, and the histoantigen testing from EMI and Eurovista. The study is being funded by the Brazilian government too, and our local infectious disease society. Next, we need more centers. So instead of doing this in Latin America, we decided it's just so much easier to do in Brazil, particularly from the regulatory aspects and logistics. So we will have probably 12 to 15 more centers. So we'll get close to 30 centers in Brazil along the next months. And we hope to move to this study. I've been designing this with my colleagues from Minnesota, with Nathan Bahr and David Bolwer. And so in addition to the induction therapy, which we aim to increase sample size, this time to more than 600 patients, we want to randomize patients again for consolidation therapy, because we only have itraconazole capsules, which is poorly absorbed. So why not testing posaconazole? Maybe we should have isavuconazole as well, but we couldn't convince the industry to participate with us because there's a lot of issues with the drug that the license will expire soon. And then we randomize patients again for duration of consolidation therapy. So 6 months versus 12 months. So we applied for NIH grants. We got a very good score, and we don't know what will come next. As you know, the situation in the US has changed. And I think this is all about connections, like all of us being together here. So it's not my work, it's a big team. So we are increasing the number of people participating. And we just had a meeting of the, someone has to ring the bell, I have 1 minute left. The number of participant centers that we have, thank you. Yeah, I'm about to finish. And so we are establishing now international collaborations and a strategic partnership with the industry and the government and PAHO and others. So we need to work all together to provide better evidence for care. And this is a very valuable opportunity for those of you who have new diagnostic tests. If you want to do that in Histo, come to us. We are collecting samples and we can evaluate and compare them. And I think this will be of potential impact on future guidelines. I hope we can, soon, let's say in 2 years' time or 3 years' time, modify PAHO WHO guidelines for the treatment of histoplasmosis, and that will also reflect on ISHAM, ISHAM, and all of the others who are interested in the fields. Thank you.
Thanks, Alessandro, perfectly on time, 7, 5, 4, 3. So the next speaker is Fanny Lanternier from France, and it's going to talk about the second life for clinical trials biocollection. So Fanny, welcome to the stage.
So thanks a lot for inviting us to present our experience with biocollection in EVAdiag Histo. So I will tell you a word of the story that Aude presented yesterday. So in mainland France, we did, in collaboration with our colleagues from French Guiana, a study about epidemiology of histo in mainland France, and Alexandre studied the results of PCR assays in patients with histo in France. And then with this data, we could see that the patient's origin in mainland France with histoplasmosis was mainly from Ivory Coast, Cameroon, and Central Africa. So then we had a question, so how could we have additional information of the prevalence on histo in advanced HIV in those countries? And so then we thought that before conducting prospective studies with all the effort it needs, it's costly and time consuming, we could start with available biocollection on advanced HIV patients in these countries, in patients that are included in clinical trials. And then as histo and TB are quite close in presentation, we thought to go in clinical trials of TB in advanced HIV. And we have the chance to have our national agency for research in HIV and viral hepatitis that we could go to find this kind of trial. So we decided that probably we could work on STATIS trial, which is a trial that was conducted to test systematic or tested guided treatment in advanced HIV adults, which are ambulatory patients with a few symptoms that have different therapeutic options for TB, and this is conducted in 4 countries, including 2 in Africa, Ivory Coast and Uganda. So this is the STATIS, and there was a biocollection from this study. So with this, we thought we could compare the prevalence of histo, antigen histo in those 2 countries in patients with less than 100 CD4. And we could also test the performance of 2 lateral flow assays. And then it was also it could be the occasion to test the practical implementations of rapid test, ELISA, and qPCR. So then there was the question on how could we deal with the biocollection. The first was to establish a partnership because we have to work with people with the collection. The first is to establish link with the people that conducted the STATIS trial. So we had the chance that they were highly supportive of this and very happy that the biocollection could be used for Song on Live. And also they were very anxious because in their different TB trial, there was still a lot of deaths and they couldn't understand it. So they were very happy we could look for a cause of death in those patients. And then we also established collaboration with the local partners, epidemiologists, researchers, and physicians on site. The second question was, where should we do the experiment? There are two options. One is to do the experiment on site. The advantages are that you need to work with the available technologies, and you do technology transfer, and also you do training. And so we choose this option. Then there were quite a lot of steps to go, because I told it was a quicker solution, but you will see that it's not so easy. So there are like a lot of steps that we wanted to share with you. The one is you need to request access to the biobank. You have to go back to the sponsor, to the research team. Then you get to have the authorization for the scientific committee of the study. And then you draft your research protocol, and then you have to submit your protocol to the local ethics committees, even if there's a biocollection, and also to get the authorization of your own country's legal authorization. And in France, it was quite a really important job. We had to go and audit this job 3 times so that they agreed. And then you have to do agreements between your centers and the center where you work to precise the terms of collaboration. So just to share with you that despite this was a collection, the patient had already gave their consent, we had to re-inform the patients, and we decided to put flyers on the site so that people could be informed there was a study ongoing with their samples. So then this was with all these few years of work to go to the results that were then very interesting with this high number that all presented and that was just published. A quarter of patients had positive histo antigen from those cohort of patients. There was an increase of mortality in positive antigen histo patients. And if we go to the dead patient of the study, a third of them had positive histoantigen. And if you go to the small population of patients who died without evident cause of mortality, half of them had positive antigen. And we also wanted to look at TB and histo co-infections. So among the TB patients, 36% of them had positive histo. And then, which is really interesting, is we had an unexpected result. It's that there was only 22% of mortality among the patients with positive antigen. And then it rises, as it was said by the editor that is with our publication from Alessandro and Ilan, that there's a lot to know now about history. And then it raises perspective. So the first one is that the same kind of trial is going on, Aude is conducting is Uganda with the colleagues. And then Aude will present the FungiCam study about Cambodia. And then to know better about the natural history of histo, we plan to do a prospective study that's called ACE that will be conducted in 3 sub-Saharan African countries. So I wanted, to go before this, okay. So in conclusion, I think that's major when we conduct a clinical trial to think to perform biocollection. Second, it's really a great tool for research. And it was not the first thing, but in the end, it's really results of really collaborative work. And it can raise also unexpected questions of research. And then also it can include the training on site and new tools that are implemented on site. But it's still a long process, time consuming, with regulatory issue, and you need a lot of energy to go at the end of this kind of work. And so I want to thank the colleagues from Ivory Coast and Uganda and Aude, for sure, who did the trial, and it's thanks to her energy that we could have those results with all the collaborative work. And I want to thank people from the Translational Research Group and with Alexandre with all his work on histo and PCR, and colleagues from Abidjan, from Uganda. And we conducted all this work with our colleagues from Fresh Guyana, Hugo and Antoine, who have all the knowledge of histoepidemiology, the work, and the experience of a lot of histo patients in their environment. So thank you so much.
Thanks, Fanny. Our next speaker would have been Thuy, but unfortunately she couldn't make it, so Diego Falchi is going to do the presentation of antigen detection in asymptomatic individuals.
Well, good afternoon. Unfortunately, Thuy couldn't come here because of the visa issue, so I will substitute her. And I will talk about the clinical significance of histoplasma antigen, symptomatic versus asymptomatic patients, some insights from a study in Vietnam, and some other data, and I think it's important for this issue as well. So the burden of histoplasmosis in Southeast Asia is unknown. As said before, we have some good data from Latin America, but from other areas, other regions of the world, this is not well known. And in Southeast Asia particularly, there is no capacity to perform the test needed to diagnose histoplasmosis. And specifically, there are no prospective studies to determine the disease burden and to evaluate this diagnostic test for antigen tests for histo in Asia. So we all know here that histoplasma antigen testing is the recommended by the WHO here to diagnose disseminated histoplasmosis with a high sensitivity and specificity. But in Southeast Asia, particularly, the performance of the test is not well known, specifically because of possible cross-reaction with Saccharomyces, which is highly endemic in this region. But another important point is that despite the same treatment, we will talk about access in the other session, but the histoplasmosis mortality in low and middle income countries is 3 times higher than the US, suggesting that maybe we do not diagnose earlier the disease, and probably a screen and treat strategy may reduce mortality. So this triple fungal screening program in Vietnam, I will present the focus on histoplasmosis of the program. It had 2 cohorts, a symptomatic cohort and the asymptomatic cohort, hospitalized patients in cohort 1 and cohort 2 asymptomatic outpatient with advanced HIV disease. And the study aimed to assess the diagnostic performance of the tests of the Clarus antigen testing in symptomatic and asymptomatic patients. So this is cohort 1, 901 patients hospitalized with advanced HIV disease, and they performed antigen testing, fungal blood culture, and conventional tests for histo, such as microscopy, cultures, and histopathology. In cohort 2, there were 500 outpatients with advanced HIV disease, and they performed only urine antigen testing systematically and cultures and other tests as clinically indicated in the follow-up. And the case definition is something important in this work because a proven, probable, or possible diagnosis require a compatible clinical syndrome. So proven with cultural confirmation, probable diagnosis with positive antigen and resolution of antigen levels with antifungals, and possible diagnosis with other invasive fungal infection at the same time, but also with clinical syndrome, without positive antigen and resolution of levels of antigen with antifungals. So in cohort 1, the prevalence of the disease was 2.9%, advanced HIV disease, hospitalized patients. Here we can see other diseases that they found. And the distribution of antigen levels was quite interesting because unproven and probable disease, much more higher levels of antigen, and possible histoplasmosis, and obviously the other no histoplasmosis with a positive antigen and no histoplasmosis with a negative antigen, much more lower antigen levels. This is important to know. I think it's a good point on this study. They tried different cutoffs, Vietnam-generated cutoffs for the test, because the sensitivity was 100% with all cutoffs. But when you increase the cutoff, you get you get a higher positive predictive value. So this is important to confirm the disease. So I think it may be in regions with a different prevalence of the disease, we may we may discuss different cutoffs. This is the changes in the antigen level across time. So we can see that the antigen level decreases, but in 24 weeks, many patients have still a positive antigen test. About mortality, mortality was higher in the group of histoplasmosis, and this is important because we know here what is the possible value of antigen testing with a prospective follow-up. But more interesting to this discussion is cohort 2. In cohort 2, the prevalence was much more lower, 0.4%. But here, I think that's important for the presentation because we have 2 patients that in the follow-up, they developed disease, so they were proven, culture confirmed and treated with antifungals. But we have 8 patients, they called here false positivity, but actually they were patients with a positive antigen, but they did not develop disease in the follow-up. But we don't know which category we can put these patients because it's a significant positivity in the antigen, but we don't know what we're going to do with them, what is going to happen to them. In those 2 patients, the levels decreased with treatment, as we showed before. And now I'm finishing, just 2 minutes. I have to mention the study that was presented before because it provides some important insights to those questions. The antigen testing in the biobank from the status trial was 24.3%, very high for Africa, and very high rate of co-infection also, 36.4%. Antigen testing, positive antigen testing was associated to mortality, 22 versus 12%. But another important point is that we had many patients, 53 patients from 238 that were positive, that they had a positive antigen, no antifungal treatment, only antiretroviral treatment, and they did not die. They were alive at week 48. So we saw that simulated histoplasmosis accounts for 3% of hospitalized and 0.5% of asymptomatic outpatients in Vietnam. The positive predictive value increased using the different cutoffs, as they said, but the high mortality of the patients with antigen testing positive highlights the need of an earlier screening of these patients when they have AHD. But many questions remain. This is my last slide. What do we need to know is the natural history of histoplasma antigen in asymptomatic patients with HIV. So we need to know who to screen and what symptoms and laboratory values could predict disease development, and what is the significance of a positive histoantigen in a symptomatic patient with AHD. Just like in crypto, the back of the slide is crypto. So we know this in crypto, but we need to transport this to histo. And obviously, if there's a role for preemptive therapy. So we are building a protocol in Latin America with collaboration with Thuy in order to study these issues. And we're applying to NIH, probably, I don't know, uncertain, but we need to do this in Latin America to really understand the natural history of histoplasma in asymptomatic patients. So that's the end. Thank you. I'll be happy to take some questions.
Thank you very much. So the next speaker would be Hugo Francois from French Guiana, External Validation of a Clinical Score.
So thank you very much. So I'm very happy to be with you today to present this project. It's a collaborative project. It's about external validation of a clinical score for Histo. So therapeutic option for Histo, it's something very simple. For now, you have severe patient. If you have a severe patient, you have to use amphotericin B, if possible, liposomal amphotericin B. If the patient is not severe, you can use itraconazole. It seems to be easy. But how to assess severity? There is a first definition of severity, old definition proposed by the CDC in 2004, with a lot of criteria. One criteria is sufficient to be severe, and it's based on two studies from the USA. And if you look closely to all these criteria, you have some criteria not very distinct, with just fever or meningitis or organ failure. I think it's not the same severity for these patients. There is another classification for severity from the PAHO guidelines in 2020. Simple definition, but with some question. You have 4 levels, and I don't know why you have 4 levels, and I don't know how I can choose between mild, moderate, and I don't know how to choose between moderately severe and severe. And for now, the question after severity is just amphotericin B or itraconazole. So why 4 levels? I don't know. And all the studies that they use to construct this classification they didn't use the same definition of severity. Some studies use mortality at 30 days, some other mortality at 90 days, some just ICU management. So it's maybe not reliable. So it's not so easy to define severity, and it's not easy to class patients. And so we need a better definition of assessment of the severity of HIV-associated histoplasmosis. That is what we believe. And this is why we try to develop a prognostic score for the 30-day mortalities after initiation of antifungal treatment. And we choose a hard criteria for the severe definition, because we think that patients with severe histo will die very quickly. So we need to identify them and to treat them with a good treatment. And so we construct a score, and I will pass about the construction of the score. So we have a histoplasmosis case fatality score, and we try to challenge the score with our own data from French Guiana. And we think that this score is maybe a robust score, and we can go on the next step. We just have to choose before a threshold. So we try to use to define a threshold with a very high negative predictive value to be sure that all severe patients who will die during the first weeks will be correctly identified by our score. So this is why we choose this threshold. And we publish the development of the score, and you can already use it if you want. And but the next step, and I think it's very important, it's why we are here today, is to speak about the next step, and it's the validation, external validation project. So for now, we have 9 countries and 16 centers will be part of the project, and from Mexico to Argentina, with some countries with high prevalence and probably higher mortality than in French Guiana. And we look for HIV in patients with proven or even probable histo, and we need just the vital status at day 30 of admission and the key variables to calculate the score. So we need a lot of patients to have a clear idea of the performance of the score. So we need more than 400 patients, and we need more than 120 patients who died quickly. So for now, a lot of centers will participate. Take time for each center. It's somewhat not very easy to have the ethical authorization or to construct a database, but we are not in a hurry. We can wait, and we can help every center to construct and to construct a database if it's not the case for now, and we are ready to help everyone to, at the end, have all the people, all the center with all the data that they have. So I just want to thank all the centers that already are with us for this project. And if you want to participate, and if you think you have data, even if it's not a beautiful database, but you think you have data, you can just send us, Antoine or me, an email, and we can see how to manage your data and to analyze your data, the performance of the score for your country. So thank you for your attention.
Thank you very much, Igor, especially for not making me ringing the bell. So he needs a prize. So the last but not least speaker of this table is my friend Cristina Canteros from Argentina, and she's going to talk about the Argentinian network for histoplasmosis. So welcome to the stage, Chris.
Good afternoon. Thank you very much for the invitation. This work is coordinated by Hospital Fernandez from Argentina, and the goal was early detection of histoplasma and other mycosis in people living with HIV, and improve rapid diagnosis approach in high complexity hospital.
Ahí con el verde.
Con el verde.
Okay.
Well, the objective was to improve the diagnosis and surveillance for opportunistic fungal infection in people with advanced HIV in high complexity, and we use a package, and this we call PAHO to simplify the use. The Hospital Fernandez started the study in 2023 in November, and during 15 months of implementation. This is a PAHO. The PAHO have HIV diagnosis, CD4 recommend, and detection of opportunistic infection, cryptococcosis, histoplasmosis, TB, and pneumocystosis. The plan of implementation of PAHO in the Fernandez Hospital, it was transferred to other 3 hospitals. One more the Buenos Aires city, and the other of the Provincia de Buenos Aires. All of them, the high complexity. The transformation include a training plan for healthcare, medical staff, laboratory technician, laboratory staff, and nurses. In July 2024, the training was completed, the kit lateral flow was delivered at the hospital, and antigen determination was performed by lateral flow and ELISA. We do a quality control to ensure the quality of the result. Well, the result of CD4 was the lateral flow was a good performance because it's detected more than 80% of patients with CD4 low level. The patient was adult, men, and a lot of exposed to harsh treatment. And the death was 11 patients, is about the 3.4% of mortality. And this is different before the POCPAC and after POCPAC. After POCPAC, the result of the study was less than 7 hours. This is, I'm going to focus in histoplasmosis. We detected 2 proven disseminated histoplasmosis, 10 probable disseminated histoplasmosis, and 1 patient with positive antigen and urine, but no evidence of systematic impact. In conclusion, the POCPAC was implemented in 4 hospitals for the early detection of opportunistic infection in advanced HIV infection, with result available on the same day. It's so important for us. The CD4 lateral flow show more than 80% of agreement with the flow cytometry, and urinary antigen identified 4.1% of cases in less than 7 hours. Overall, with mortality was 3.4%, suggesting a benefit for early intervention. Well, thank you very much. Obrigado, muchas gracias. This is people who work in this work.
Thanks very much, Chris, and also thank you very much for keeping to the time. So 2 minutes left. So I think that's a good sign because we have time for 10 minutes, no, 20 minutes for questions, right? Where is the boss?
20, plenty of time now. Relax. Can I ask a question, Anna, please?
Alessandro, yes?
Oh, yes, please. My question is for both EMI and Mira Vista. Do you think we should be using the same cutoff for any sort of patient, like HIV, non-HIV, mild disease, severe disease, asymptomatic, severe patient? It's about cutoff for diagnosis. Thank you.
Who's going to answer this? That's the problem. So, shall we ask?
I was going to ask a similar question. So, I think Diego's presentation was really great in that you're looking. Diagnostic assay is looking for infection, versus clinical disease is a separate entity. And so usually we're using diagnostic assays in people who are sick, and so but when we're screening people who are asymptomatic, it's a different situation. And so the same thing with cryptococcal antigen. If you have a very, very low grade of cryptococcal antigen, you give people ART, they do fine. It doesn't mean that it's a false positive test. It just means that they didn't develop disease. And so, okay, so I think it's great that this is actually really great data to show, like, oh, if you give people HIV therapy, there's a level of which you don't really need to treat them otherwise with antifungals, that they just have asymptomatic infection and it self-resolves and they live happily ever after, which is great. But there's an above a threshold where you do have to treat them and they're not going to do well with HIV therapy. So I think that's really great data that's really informative. And it does speak to, with HIV, you can give people HIV therapy, you can immune reconstitute, and so it's a different situation than a transplant or some other population.
Diego wants to comment on that, but you need to, we need, just for you to, we need 2 microphones because there's one for the audience here and one from the audience in the virtual. So please, whenever you talk, you need to have two things close to you.
Okay.
Two
Can you hear me?
electronic things apart from your phone.
Can you hear me?
But
Yes.
can I answer now? No?
Okay.
Diego
Which Diego?
Cáceres,
Oh, yeah.
sorry.
Two
There are
Diegos.
too many Diegos, too many Diegos.
Okay, so maybe.
They request to me, so I think that was for you.
Okay. So maybe, as you know, before I joined IMI, I had the opportunity to evaluate the both assays, the IMI and the histoplasma. Can you hear me?
Not
Now?
good.
Now? Okay. So, as you know, I had the chance to evaluate both assays even before I joined IMI, but we did this validation using a cohort from patients, prospectively collected, and were done in symptomatic people with HIV, no? I think all this new information about the screening is still early. I think we need to do more ongoing studies, maybe more prospective clinical trials to evaluate the role of the antigen for screening, no? So we know the performance for people that we are suspecting of having histoplasmosis, that is a risk of histoplasmosis. But for screening, probably is early at this moment. And maybe I want to do another question for Diego. I know it's a TU presentation, but you know is the data about the concentration of the antigen using the standard curve method is available? Because I see all the data is presenting the calibrate, is what does use the calibrator cutoff method. It's a little bit technical, but.
I like this dynamic. So he responds to a question, so ask to the next one, so you can respond and then ask your next question.
And let me just say one thing first to add. I think we should be thinking about, and Diego, you remember this, when we did our CDC test before IMI had theirs, we got very good results in serum with that test. I think we should be considering serum now. If we're going to be screening like we screen with crypto, where you do a Visitech CD4, you do a crypto test, you do a LFA, you know, I think we should be thinking about sera testing and not urine testing for histo. I just throw that out to think about it.
Agree.
Okay. I'll try to answer first the question from Diego. I don't have the data, the specific data on the technique on this antigen methodology, but David has commented before about the antigen level and in asymptomatic people. Those 8 patients that they did not develop disease. I think they are in the same category of those patients in the quoted box study that which not received treatment and remained alive. We don't know if they remained without disease because we don't have this data on the paper, but probably they are in the same category, and we need to know who are these patients. So we need more data, we need more studies to prospectively study the natural history of disease and to identify patients only with infection. If they get antiretroviral therapy, they will solve the disease, and they do solve this infection, they control this infection, they do not develop disease, but other patients that are at high risk and they need probably preemptive treatment.
Next question there.
Oh, I was going to reinforce exactly what Dave Boward mentioned. The antigen test actually goes against the calibrated curve. So if you have the presence of the antigen's there, and likely the infection is there. But as Dave mentioned, you know, if the patient is actually immune reconstituting, maybe they can get better on themselves. That doesn't mean that they didn't have histoplasmosis. It's just the immune system is getting better. But I wouldn't necessarily change the cutoffs because of that.
I'm going like this. So Juan Luis?
I would like to have a comment about the threshold, because it's a very risky business to start again and have different thresholds and different populations. If we want to put in the equation the predictive positive values, we need to know pretty well what is the incidence and prevalence of the infection, because change dramatically depending on the prevalence of the infection, the positive predictive values. The positive predictive values and negative predictive values cannot be calculated. You can calculate it, but shouldn't be calculated without knowing the prevalence of the infection. So we need to be very aware, because it's a very risky business. You need to do prospective studies, and it might be you need to change threshold in different countries. So be careful with that.
Thank you. Yes.
I'm from the group from Venezuela. We conducted the cohort study in a chronic, I have this one here, in the chronic population, in the chronic pulmonary histoplasmosis population group. And as we've discussed so many times among us, and I think with Diego Cáceres too, our cohort let us know that maybe we need two cutoff points. Maybe one for people living with HIV and one a little bit lower for people with chronic forms of histoplasmosis or non-immunosuppressed associated to HIV, corticosteroids, alpha blockers, anything of that. And so I have to take this opportunity to leave this comment on the table with the experts, because for us, this was a tremendous finding, and we are advocating for 2.2 cutoff points for two different populations.
So but in this study that you're mentioning, so you were screening, so you had chronic pulmonary histoplasmosis, and you want to decrease the positivity with the ELISA, so would that be useful with the lateral flow, because that's like next step?
We only work with ELISA. We didn't work with Miravista. We only work with ELISA.
Yeah, so the problem would be here, and it's open for discussion as well. What happened then if we move to the lateral flows now? Are going to be able to have set this cutoff at some point or not? And my second question to you, I'm sorry, as we have time, I can also ask questions. It's have these patients been treated, and are they improving? Do you have the response?
Yes.
To which antifungal were?
Yes, we follow up for a year, because we follow it's a guidelines to treat them, and we follow up by clinically and radiographically improvement, and as long as we can be in touch with them, over 70% of our population improve.
Perfect, thank you.
Thank you.
I don't know if anyone wants to comment on this, or are different comments. So Diego wants to comment. Diego, please.
Yes, complementing Romi's comment. So I think for chronic pulmonary, and also adding to Tom's comments about SIRA, I think it's important to also evaluate these commercial kits for other specimens different than urine, including SIRA, respiratory specimens, and also there was a poster from Argentina for the detection of antigen in cerebrospinal fluid, no? And also apparently the antigen testing is performing very well for the detection of histoplasma meningitis, no? So maybe complementing Tom's comment about like expanding the specimen testing to urine to another different specimens depending on the clinical flow of the patient, no?
And with that, I also would like to ask Fanny, because if I remember correctly, you said that you were comparing the two lateral flows, ELISA and the OIDX, and did you find any difference in that? Because I'm just pointing this out, probably in Histo, it's not that, there are not that many tests, but we know there are many in crypto, so how important it is to evaluate these different tests? So if you compared the two tests, the OIDX and the Miravista, and because the results that you put was only the Miravista, so if you had some results regarding the comparison of both. Yeah. You need two microphones and you have none.
Yes, so we studied the performances of these two lateral flow, Miravista and OIDX. So we've got very interesting results with Miravista. It was specificity and sensitivity and specificity 81% and 88%, compared to OIDX. It was specificity like 73% and 33% for sensitivity. So it's a lot of false negative and also false positive.
Thank you.
And we did this comparison only in patients at risk for histoplasmosis.
Yeah, so it's so important, the different tests, and now that we are probably going to have more in the market, it will be interesting to see how the results are. And now David was waiting for a while.
Yes, so I wanted to make a completely different point about amphotericin doses. So this 10 milligrams per kilogram of amphotericin makes no pharmacological sense at all. It doesn't need to be that precise. If you look at the PK of liposomal amphotericin, it's all over the shop. And so I think we as a community and maybe the company have made a strategic error in using these milligram per kilogram doses instead of 500 milligrams or 600 milligrams. Vast majority of antibiotics we give as a dose, not as a milligram per kilogram. It's quite rare in infectious diseases to use milligram per kilogram. And this makes it harder for pharmacies to dose the treatment. If patients change their weight, the dose changes a little bit. I think we should be using fixed doses, maybe in some weight bands if a patient's very small or very large. But I think this precision is not required for this drug.
Any comment of that or new questions? So I think David was first.
So I'll respond to the other David's question or comment. Yes and no. I think you could do weight bands, but because the patient weight may be so variable, you could be 40 kilos or 80 kilos, like that could be vastly different dosing. But I think, yeah, you could certainly do bands and make it much more simple than it has to be precisely 10 milligrams per kilo. And I think some of the new drugs, the Safunga, Alien Therapeutics is an example where they're going to do 2 milligrams per kilo. But like, are they making a mistake where they could just simplify it and do sort of a simplified dosing instead of this really super precise thing? But my other comment was about the false positives. I'm really on the false positives here today. But in a research study, those may be false positives. They get ART immediately and life is good. But in the real world, things may be very different. And so Nelesh's data from South Africa on cryptococcal antigen screening, half the people never came back to get their tests. And so these false positives with histo, if they don't come back for a month or two, those people are going to progress. And so that may be very useful information for the clinician still to have. And so I wouldn't say, oh, it's only 20% of people who actually have disease. And I wouldn't discount that because in the real world, things may be very different as far as how quickly people actually get on HIV therapy.
Yeah, thanks very much, David. We have just last question from Alex, and then
yeah, it's more a comment on the screen.
Sorry, Juan Luis, last question.
Sorry.
I thought you were going to the microphone, and I know you too well.
So it's a comment on the screening strategy, and coming from a place where we have a lot of hematology patients, and those of you who are taking care of hematology patients, you know that we are screening patients at risk, those hematology patients, sometimes twice a week with galactomannan. And we know that galactomannan is sensitive, and we know that we are exposed to false positivity. And so the screening strategy is you select people at risk, you detect those positive patients, and then you have to confirm the infection. So if you use a screening strategy, you then use a very sensitive test, and then you have to confirm all those positivity. And so I know in specific kind of diseases and in specific fields or countries, you cannot do that. But if you are thinking about the screening strategy, you have to have that in mind, meaning that you have to confirm those because you have a high risk of false positivity also.
Thank you. Thank you, Alex. Thank you, everyone, for the engagement, the nice discussions, and all the speakers for their contribution.
All right. So before the coffee break, would like to share with you.
I leave the bed here.
Yes.
Green further?
Green further.
Yes.
Okay, so just before the coffee break, we want to share with you.
You're welcome.
Information and then slide also before so the people will maybe have a picture up to the desk there. So just to remind people, so some of them were there, some of them were not there. This is the story. Many of you have seen those pictures. So we've been committed statements, and so Tom was pushing a lot for this. We need to have a statement by the end of the meeting. Otherwise, we cannot perform advocacy. And we know Tom is good at advocacy. So in 2015, we were committed, so 80 by 20 was a simple message. And it was mainly 80% of reference centers with tests for histo. And at that time, it was the only, we only had the second generation of ELISA tests for IMI, no lateral flow. Then we moved to the Manaus meeting, and we went in the end with the new one. So Tom was saying we need to be ambitious. So let's say 100 by 25. And so at that time we knew, so Diego did, we did a few interviews among the participants. And so we knew so that there were less than 50% of the countries participating in the meeting that were equipped with the tests and even the drugs. And so it was 100% of countries that will be equipped with tests and antifungals by 2025. So now we think we should move to a call for action. So we've been discussing with Freddy, with other people of the fungal priority lists. And so we think so there is a need to call for action for 2030 this time. So we would like to make a proposal, so that is open, and we would like to change the way we frame the call for action. So it's not only a number and a date, but maybe we should frame it the way, so Nelesh showed the cascade for the care of crypto. Maybe we should have a kind of a framework like this. And so this could be the proposal. So this is to discuss. It's like in population at risk. So we would aim to have 80% of people screened. Among them, 80% on antifungals, and among them, 80% of survival. It could be 80, 80, 80 by 2030. So it's open to discussion. So idea is to put this on the table. We have then the picture, coffee break, and then by the end, we will have a conclusion. So it's around 5 o'clock. And so we could discuss this at that time. Or if anyone is willing to comment right now, but I think it might be a big discussion. So, yeah. So, you want to comment? Yes.
Thanks very much. I think it's a very nice proposal. I'm just wondering if we should increase the survival, providing that even in patients that are HIV advanced positive, antigen positive, the survival is like around 80% or 70 something. So maybe we should say 90% survival or something like that. Just a comment, but maybe it's okay 80. But I feel like if we want to be ambitious.
Yeah. This is a proposal. You know, it's a new way. So framing as a cascade of care. So, and according also to this database from PAHO, maybe that may help us also. So it could be a way, and is it in countries? Is it in reference centers? So then we need to have a framework of evaluation also that goes along with.
I just wanted to add that we shouldn't, we really should be thinking beyond Latin America. I mean, we need to be thinking about Southeast Asia and Africa also. And so I really like the shift away from access to, just diagnostics and treatment and looking at the cascade. It fits really nicely also, but I'm in support. One minor point, if we're screening in patients, maybe we should be talking about diagnosis rather than screening, because screening implies asymptomatic disease, which we are not proposing at this point, I think.
Okay. Tested, yes, tested. I should too.
We should talk about resistant action towards targets. I think that's too localized. I think maybe Brazilian or Latin targets or ISHAM targets. I know that we've historically had a to attach to targets. I think this will be seen as a too localized to Brazilian to it's a holiday destination. So maybe we were all on holiday in the fall, so we weren't
So I think whatever the terminology for the targets, I think we need to think about something which isn't quite so localized and quite so obviously a holiday, beautiful destination.
Yeah. I agree. So just to comment on, this should be global. So it's ISHAM targets, whatever. So let's go for ISHAM targets. We can go for this.
We haven't got much time. If you could, we have time for 2 quick questions, please.
Yeah.
Was just a comment. Just say I would like to understand what is in population at risk. It's a primary pathogen, and for instance, Guillermo has 5% of incidence in kidney transplant patients. So you look in population at risk, the first thing you think is HIV, but I think there are many more population at risk and should be defined.
Yeah. Yeah. So Heidi was to define these, have the case definition for each step, maybe, or even the situation of starting situation after, because I think in centers they might be interested in testing people, transplant people. Other centers will be TNF blockers, other will be HIV. So the idea is that people will engage in the strategy, get tests, get treatment. So it's more open. It's out of LATAM and it's out of HIV. It's not only. So this is why we put this.
My minor comment is this is really nice, this kind of framework. But I wonder if we're screening in patients or diagnosing in patients, shouldn't we be a little bit more ambitious on how many of them should be an antifungals, considering that they are all diagnosed? Survival won't be 100%, but perhaps we should aim higher for patients who are diagnosed to have access to antifungals.
Yeah. If all of us, we want to be more ambitious, it's not a problem. We can, with pleasure.
May I invite you all, please, to join us at the stage for a picture.
We'll take a picture.
Historical picture of the first ISHAM Histo meeting, please.
Who has the best camera to take the picture?
Come on.
Oh, here? Yeah. Come on. Yeah. Maybe the tallest could be...
Yeah, stage diving.
Okay, join us.
Yeah, yes, please. Yeah, yeah. Yeah, please. Where's the picture?
Yeah. Where's the guy? You should stand on a... He's there. Yeah. You should stand on a chair.
Ô meu, ô velho, sobe na cadeira, pode ser? Profissional, né?
You cannot see here? For this side, no?
I can see enough.
Something's wrong. Oh, it's mine. Thanks. Yes.
Vem pra cá pra frente.
Não, tá bom, aqui.
Não aparece não, fica cá.
You all right? Oh, there you are.
All ready?
Peraí, Adelaide vai aparecer, que ela tá...
Look forward. Cheers. Tira vários. Thank you. Yo! Coffee time! Muito bem, well done. E aí, Cezinha?